It is a great honor as a patient with sleep apnea and you use the CPAP as a therapy and a representative of the Italian Apnoic Patient Association to present the reading of Professor Colin Sullivan, known globally for inventing nCPAP in 1980. He will present the history of nCPAP from 1980 to 2023. I thank a lot Professor Peter Cistulli for facilitating the outstanding event. I leave the floor to Professor Cistulli. Thank you.
Grazie Luca, è un grandissimo onore presentarvi al professore Colin Sullivan, che sicuramente lo conoscete tutti. Lui è stato un mentore mio, è stato l'ispirazione di seguire una carriera come clinico e ricercatore come lui. Adesso parlo in inglese così mi capisce anche lui. So Professor Sullivan has had a very long and distinguished career as a clinician and as a researcher, and he has made critical contributions in clinical research, in clinical management, the commercialization of medical innovation. He has been a mentor to many researchers and clinicians in Australia and overseas, and he has also been a leader of many organizations, particularly professional organizations. Of course, he is best known for the invention of CPAP, and in that way he is one of the fathers of sleep medicine. This remarkable invention has impacted the lives of millions of people around the world, including many people in this room. And so that achievement alone is enormous. But it is important to recognize that he has made many other contributions to our understanding of breathing during sleep, and in more recent years, in particular in infants and also in pregnancy. And as you heard earlier in the presentation on non-invasive ventilation in neuromuscular disease, it was really the invention of positive airway pressure that revolutionized the management of respiratory failure. Of course, I could go on in describing his many achievements and many accolades, but importantly, I want to end in telling you that Professor Sullivan has always placed great importance on the voice of the patient. And he was instrumental in the establishment of Australia's first patient support group, which is similar to the Associazione Apnoici who are hosting this conference. And so it's very important and appropriate that he is presenting in this conference. So with that, I'll hand over to you, Colin, and we very much look forward to your presentation.
Thank you very much for that introduction, Peter. And thank you to Dr. Roberti for inviting me to give this talk. One of the few great benefits that have come out of the pandemic is this ability to communicate from the other side of the world. So it's really quite remarkable that I can be here in Sydney and yet spend some time there with you in Italy. I'd like to follow up on that comment first about the patients. That's indeed when we first began to diagnose and treat sleep apnea. Very few medical colleagues and administrators were interested in the problem at all, and it was the patients that helped us get the funding that we needed. Now, am I... Good, thank you. Before I talk too much about the CPAP story, I really would like to acknowledge Italy's foundational work in sleep apnea. And I've got a photograph, of course, of Elio Lugarisi, who I'm sure all of you know, but I just wanted to remind everyone, and probably the younger colleagues here today, of just how important the contribution was that came through Elio's work. There were several key papers or discoveries at the beginning of the sleep apnea story, and the first of which is Gustave Tassinari and Giron in 1966. And of course, they identified upper airway obstruction, but I'll point out they had identified it in one patient. I think they had a second patient. But in fact, apart from that publication, they did not continue to work in the area. I think most of you will know that, of course, Dr. Tassinari was a neurologist who was part of the group at Bologna and has remained there as a neurologist. The second important paper was that of Kulo, Jung, and Frank, which was from Germany in 1969. And this was the first tracheostomy. And what was very interesting to remember about it, and you only do this through reading the original papers, is that the patient they had was in really terminal respiratory failure. And so their brave decision to do a tracheostomy, of course, ended up with what was a miraculous recovery. Again, as a group, they didn't follow up. Now, I understand that, in fact, all of these people in each of these publications started this at a conference that was held in a ski resort. So they were all aware of the discovery of obstruction right at the very beginning. But in fact, it wasn't until Luca group took it up that in fact, the work continued. And unlike the other two sets of researchers, Luca and co. really established the major research program. And he, of course, had numerous patients with tracheostomy. But what's so important is they also did arterial intravascular pulmonary pressures and systemic pressures in patients during sleep and showed the dramatic effect that sleep apnea has on the cardiovascular system. I think it's really important to go back to these original publications because so much of modern research is really repeating these experiments and doing more patients and, of course, getting more out of it. But in fact, the link to hypertension and the changes that occur in the vascular system were already discovered there by Luca and his team. And I want to show some of the results of a paper that was published in 1980 in the journal Sleep. And I'll talk about it again in a moment because it was at a meeting we held in Sydney. And Lugarisi's group presented the first epidemiologic study of snoring, showing the increase in prevalence throughout the age and both men and women, but with women delayed by about 20 years. Now, what's really important is that in this study of heavy snorers, which was done in San Marino, they did identify the link between heavy snoring and high blood pressure. But equally importantly, they found that the problem was much more marked in women, and that's something that has been neglected until recently. And we know that, in fact, the original work has actually been borne out. So I'm going to spend the rest of my talk giving you a very personal account of how CPAP came about. And when I think about it 43 years on, one of the first things that I remember, and in fact, I think is probably one of the most important aspects of the whole work, is that the CPAP method provided us with the most extraordinary experimental model so that we were able to take patients with severe disease, make a lot of measurements before, then treat them and make measurements after. And that experiment continues to be used extensively. There's not a month goes by that someone doesn't publish a paper showing how some variable, right down to the cellular level, is altered in sleep apnea and how it's reversed by treating the sleep apnea. And of course, we all now know it's the frontline therapy. I can tell you at the beginning, there was no thought that that would ever happen. but now we know it is remarkably effective. And in fact, it's very safe. There are a few adverse paper reports, but given the numbers, it is very safe, unlike most drugs. And it certainly stood the test of time. The third really quite remarkable aspect of CPAP is that really it was invented, the problem, before the extent of the underlying disease was known. I think it's very difficult for people today who know a great deal about sleep apnea to actually imagine and realise that in 1970, the late 1970s, early 1980s, sleep apnea wasn't part of general medical understanding. Sure, there were a number of groups doing research like Roberti, like Guilleminault, etc., and our own work. But in fact, we had to fight to actually get any resources to actually try to study the problem. And in fact, initially, we didn't have any patients. The final comment I'd like to make is that there is no doubt that CPAP has played an incredibly important role in the development of sleep medicine. Before CPAP, the polysomnographic studies, sleep studies were all diagnostic. The moment we had started putting people onto CPAP, the sleep lab itself became a clinical service. It became a therapeutic lab. And if you look at the data of how sleep labs developed, it was only after CPAP became widely available that there was an explosion of laboratories around the world. So I have made a few notes, and I don't expect people can read them all, but just to remind me to think about, here we are, it's 43 years later, and CPAP has actually been used to the extent that it is. I presented we did the first experiment in 1980, and it was published, as most people know, in 1981. But I presented the first experience with home treatment with CPAP to the American Thoracic Society in 1982. And it was an extraordinary experience because there was a great deal of interest, and those people doing research could see it immediately was an incredibly useful research tool. But in fact, most clinicians, and I'll probably dare to say almost all the clinicians that were there, were incredulous that it could be possibly ever be a therapy. It was regarded as a bizarre idea. And the question that always arose is, well, why doesn't the air just come out of the mouth? And in fact, CPAP was initially only used by a few groups who had the capacity to make their own equipment in those first years in the early 1980s. But after the commercial devices became available, and in fact, some of the many publications that come out of ours and other labs showing how effective it was, the use of CPAP into the 1990s obviously expanded greatly. What's interesting about this whole area is that in the mid-1990s, there was a great question mark about the veracity of CPAP as a therapy. And there was a very now famous paper in the BMJ by Wright, which really was saying, well, look, there's no good evidence. There were no RCTs. I mean, it was interesting in a sense that they didn't, these people writing these papers were not clinicians, and they didn't experience the dramatic response that patients who had severe sleep apnea responded after therapy. However, they did us a service because it triggered the development and funding of numerous RCT studies. But I think, as most people will know, a lot of those RCT studies have had a negative effect on the use, largely because of a failure to find much in terms of outcome. But almost all of them have been problematic because of the patients that they used. And this was actually summarised recently in last year in Raynor in Sleep. where they looked at all of these RCTs and identified that the patient groups were just not the patient groups that clinicians see and with severe sleep apnea. And part of the problem was that most people felt that it was unethical to, in fact, enroll patients with severe disease in a randomized trial where they wouldn't get treated. So I think that's a really important problem, but it's a problem that continues. I mean, even as of the end of last year, a big US federal government funded report suggests that we still don't have good enough evidence to think that CPAP works long term. I'm going to quickly just refer to a couple of really important papers. This one is from Marin. It's now a long time ago itself, 2005. And there they showed, in following up patients over 8 years, that patients with severe sleep apnea had a marked increase in their cardiac deaths and infarcts, and that those on CPAP actually had a dramatic improvement. Now, this data, of course, had the criticism that it could be the healthy user effect, but I think that's very unlikely. What I can say is in the last few years, there have been new data coming out, and I just refer to this one paper from the French group where they've looked at their entire, the French system as a national health record. And what's interesting, this refers to 88,000 patients who went on to CPAP and stopped it, versus 88,000 who went on to it and continued it. And over this short period, really 3 years, there was a dramatic difference in terms of survival. So those who stayed on CPAP had greater survival. And in fact, the incidence of fatal heart failure, incident heart failure, was very strongly related to severe sleep apnea, not using CPAP. I put that in here because, again, the criticism, is it a healthy user effect? But it also just shows you the astounding number of people who are, in fact, on CPAP and are getting benefit from it. So I think I'll go very quickly to give a brief background about where did the idea to use CPAP come from. In a way, it's always been a question that I found difficult to answer, but I think it's my own background that I was always involved in doing experiments. I had two older brothers, both of whom were engineers and physicists, and I think I was introduced to doing experiments very early on in my life. And I was attracted to medicine because of thinking of the body as a machine, and particularly physiology. During the course of my medical training, I did my first research year in the middle of my medical training, where I in fact studied carotid body sinus receptors, baroreceptors and chemoreceptors. And that actually made my interest develop. After I actually had completed my medical training and specialist training, I then came back to the university to work with my mentor, David Reed, to study control of breathing. And we were interested, and he was interested in SIDS. And what's remarkable is that, in fact, that's when we first became aware of sleep apnea, through the Rimini Symposium, which was run by Elio Luca in about 1972. But this was before the internet, and we had to wait for publications, often over a year, for our library to get the publication. And when that publication arrived, we were, for the first time in 1975, become aware of sleep apnea. That led on to me doing more research about how breathing, how sleep affects breathing. And I spent 3 years with Elliot Phillipson in Canada. He had developed a model of trained dogs who would sleep, that he could study their breathing. And I joined him for several years, where we had a very productive few years of doing very basic research. And then I returned to Sydney, Australia in 1979. My job at the hospital was to set up a respiratory failure clinic. And I also set about doing research, continuing my research on breathing in sleep. I think I'll just put this up here is that, in fact, this idea for CPAP came to me really based on this long background of doing research. And in fact, it was always clinically focused research and looking at how we can treat the patient. It didn't just come out of the air one day. It was actually, I was actually trained to think of it. So the work that I'm going to show a few quick slides to show the sort of work I was doing, which will probably help to inform you of why it was that I came up with this idea. First of all, this model Elliot had going, that the dogs were initially used for exercise studies, and one of the dogs went to sleep one day and he kept measuring it. But the dog had a permanent tracheal fistula that allowed us to measure airflow. You'll notice here, this is the original Hewlett-Packard oximeter, which was a major breakthrough for us to study humans. So in fact, when I returned to Sydney, I decided I would set up the same dog model, but I wanted to start to try and work out whether I could do the same sorts of studies in humans. So in fact, while I was waiting to actually get the equipment, we actually managed to organise a research meeting in Sydney in 1980 in March. The reason I wanted to show it today, the publications in that meeting are all published in a special edition of Sleep in 1980. They're still available online, and I would strongly urge any of the young researchers to go and look at those papers. But in the audience, we had Elio Lugarisi and I wanted to show you and Elio Lugarisi and Christian Guilleminault, John Remmers. We even had Bernard Giron of the Tassinari Gasto fame. But what was interesting is that Christian Guilleminault and Elio Lugarisi had recently begun looking at the upper airway with a fibre optic scope. And so had Professor Weitzman, who was in New York. Well, at this meeting, they showed these pictures of the airway collapsing during sleep. And what was interesting is while John Remmers and Christian Guilleminault favoured a passive closure, Elliot Weitzman and his group looked at the changes that occurred during sleep. And in fact, the closure sort of would occur very suddenly. And he was convinced that it was actually the result of spasm. And in fact, that's one of the reasons I was thinking, well, how do we actually work out if this is passive or is it induced by a reflex closure of the pharynx? And that's what made me think, well, if it was passive, I should be able to keep it open and let the subject breathe if I applied some positive pressure. But if it was a phasic or a spasm of upper airway muscles, it probably wouldn't work, and we'd see this closure on our pressure tracers. At the same time, I had started doing studies on our dogs, and what I wanted to do was look at the upper airway versus the lower airway. And so I had to develop masks to do this. So you can see where this is going, that in fact I was already working on this. And in fact, the first of the experiments we did in dogs showed when you occluded the airway at the trachea, you actually didn't get much response at the genioglossus. But if you occluded it at the nose, you got an immediate response at the genioglossus. So it was one of a series of studies of which we were very early on in it, which showed very powerful upper airway reflexes in sleep, which in fact, a loss of those may be one of the mechanisms. So how do we do it in humans? This is the next question. Well, how do I do these sorts of experiments in humans? And this study shows three of us. This is Faik Issa, who was my first PhD student, who was one of the team. and he's got one of the black anaesthetic masks on, and they are really very uncomfortable. This is Mike Burton-Jones, who is my second PhD, and he's setting up our polygraph, and Michael was part of my team. And this is me, although probably unrecognised now, but trying to find ways of how do we measure breathing while people sleep. And in fact, this is the device that we came up with. In fact, this was a whole set of apparatus that was literally glued to the nasal airway with prongs and with a mouth glued as well, so that we could have a bias flow and measure airflow, but also we could induce obstructive apnea. So we were faced with, I was spending my time thinking about what is the mechanism of upper air closure. I was convinced it was almost certainly passive closure through a loss of muscle tone, but there was a lot of possibilities which might have come in. So I was waiting for a patient. One of the interesting things is that in 1980, we didn't have any patients. I had to go looking for them. And so the first patient who was available to do a study on was this man. And this is the middle of 1980. He's a 43-year-old man who had severe sleep apnea. And in fact, they refused. I had strongly recommended tracheostomy because it was such a bad severity of apnea. But here he is with, we had a pair of nasal prongs, which were fitted into this thicker tube, and big tubing, which allowed high bias flow going through a resistance. And at the other end, there was a variac, which allowed us to decrease pressure. And of course, we did this experiment at 11 o'clock at night. Well, I quite expected that if it wouldn't work and we'd be at home at 1 o'clock. But here is what happened. The result was very clear. It worked. And I'm showing you, this is one of the first original records, very slow recording. We're looking at heart rate, oxygen saturation. You can see these are individual apneas, chest wall, abdomen, CO2 in the airway, pressure in the nasal mask, and EOG, EMG, and EEG. So here's a run of obstructive apnea. So really quite severe obstructive apnea. Desaturating not too badly in this case, down to in the low 80s. And at this point, you can see I'm turning up the flow into the system. And at this point, you'll notice there is actually, it's switched from complete apnea to what is partial obstruction. This is what you get with heavy snoring. And this is still partially obstructed. Increase the pressure a little bit more, and suddenly the airway is open. And now look at the CO2 is coming down. And what you will notice is he's gone into REM. And in fact, you can see that from even though these are very compressed records, you can still see the dramatic increase in eye movements and the fade out of muscle tone. And look what happened. What would you do? I must say, everyone these days has protocols written up and checked, and I didn't have a protocol. I would try it out. So it worked. So what I did next was to drop the pressure. And of course, the sleep apnea came back immediately. Look at the difference in saturation. This is the classic change that you care with REM. So what would you do next? Well, I'll increase it again. So there again, it stopped the apnea. So this was not a biological experiment. It's a physics experiment. This is something that all of the people who worry about the statistics of randomized controlled trials don't realize that this is actually a physical experiment. We are demonstrating, and can be demonstrated, that the problem of sleep apnea can be turned off and then on and then off again by just manipulating the pressure. Now, in fact, I did think right at this moment, I remember thinking, well, it could be reflex. So what I thought, let's just keep, after we'd done 5 of these cycles, all with the same result, decided let's keep him going all night. And that's exactly what happened. So we kept him on this pressure all night, and he had the most extraordinary sleep with the most incredible amount of REM. He had 2 hours straight of REM, and then there were long periods of deep slow wave sleep. And of course, This is from one of the other patients showing typical severe sleep apnea. This is the sort of patient that you don't need an RCT to decide whether you're going to treat them, but you know this is going to kill them at some point. So this saturation is going down to 50 in REM, and here's the same subject on CPAP. And I suppose this slide really captures the experimental value of the CPAP experiment. And we set about to do, and many others have now and continue to do so, measure all sorts of things in the patient, blood pressures, pulmonary pressures, hormones, etc., before and then immediately after treatment. It's sort of a classic experimental model that you usually relate to having an anaesthetized animal, but this is an experiment of nature that the patient has themselves with repetitive hypoxia and then the use of CPAP. I'll show you, this is a photograph of the patient next morning, and you can see the prongs, and he'd removed himself. He was wide awake after 7 hours of sleep. He was absolutely bewildered. He was looking at the nasal tubes and wondered what had happened. I noted he had a return of colour vision and there was a complete lifting of brain fog, but I don't need to go in and you know the recovery that occurs in this. So we had an avalanche of experiments and I won't go through any of them, but in fact, there were just too many opportunities. It was the most exciting period in our work. I do want to show you one of the classic sleep rebound studies. This is published years ago, but this is the sleep staging with severe sleep apnea, and every one of the arousals caused by the apnea is shown here: 98, 89, 85, etc. Here's the same patient the next night, and every one of the arousals is now marked. And look at this dramatic effect, not only on his breathing, but on his sleep. And here's an example of 2 hours of continuous REM sleep, which you simply do not see under any circumstances. The other comment I will make is that we had a lot of patients in respiratory failure, and in fact, just by putting them on CPAP, that respiratory failure worked. The other thing we found I had in these early days, this is a 60-year-old woman with biventricular failure. She had a very narrow upper airway, and she had biventricular failure, which resolved on CPAP. I put it up there because we sent it off to be published, and the cardiologist wouldn't accept that that could have possibly happened. Now, I'm very aware of the time that I'm going over, so I'll finish up in a few moments by just showing you some pictures of our early means of how we treated it. So it was a great experiment, and the next question is, would it be a viable treatment? And initially we were doubtful. We thought it would be impossible to get people to take it. But of course, to do that, the patient would have to be able to look after themselves. It had to be fail-safe at home, easy to use, and it had to allow the patient to sleep after their sleep rebound. In all our early studies, many of the patients were very easy to put on this apparatus because they were so sleepy. So you'd treat them for 4 or 5 days, and then on Friday night when we let them sleep without the CPAP, they didn't sleep as well. So we thought that, yes, we may be able to use the CPAP as a rescue therapy to keep them alive before they have a tracheostomy or other surgery. But we didn't think that when they recovered that they'd be able to tolerate it. And of course, the issue of the fail-safe is that because the CPAP works by going through the nasal route. And in fact, as people were incredulous before, thinking, well, why doesn't it blow out the mouth? What it actually revealed was an important anatomical reality in sleep apnea, at least most of them, is the overlapping of the tongue and the soft palate. And when the airway is pressurized, it seals the oral cavity. And that's why CPAP works, in a sense. And that, at the same time, meant that we had a fail-safe device. So it could be put onto the nasal airway, and we literally glued it onto the airway. But if the device failed, they still got their oral airway and they respond appropriately. So, in fact, one of the important things to realise is that the circuit for CPAP, I won't go into, but it was quite a novel circuit because it has to have a very low impedance. So you've have to have a very high flow with a low impedance that doesn't add effort to inspiration or expiration. So it's a key. Now, here, all of the first set of patients, we had 5 patients that we studied in that first few months, and this is one of them. And all of those patients were lined up to have a tracheostomy, and this fellow was lined up to have a tracheostomy. And after he'd used the CPAP, said, "No, I would rather use the device at home." So he was the first patient to go home. This is the apparatus we started with. And this is a vortex blower, which was a source of a lot of high airflow, which we'd leak at the origin. And here he is on the device he was going on. This is him 30 years later, and I won't go into his story, except he was a very prominent businessman. He'd lost his job, went on to CPAP, got his job back, and was very successful. He was on it for 30 years. He died only a few years ago now of chronic myeloid leukemia. So this is what we used to do. We actually made the masks because at the time there were no masks that were suitable. We mould this fiberglass mask, and we'd use this elastic to actually glue it to the nose. And we could use, once it was peeled off in the morning, sometimes they could use it again another time. But in fact, with this system, of course, we didn't have many leaks. However, I set about doing a lot of work. One of the features of my facility was that I had a mechanical workshop, an electronic workshop, classic physiology laboratory, and these were the first of the masks that came up that we did not have to glue on. I'll just finish off by saying that at this time we did the first patient, I had a couple of patients in hospital, one with kyphoscoliosis, another one with muscle dystrophy, who we were using a body box to ventilate them. And we'd found, like others had, that in fact, when they went to sleep, they would actually get upper airway obstruction induced by the negative pressure. So we, in fact, immediately tried CPAP, which worked. It meant the ventilator worked well. But that really immediately occurred to me that, well, why don't we add pressure to that using the CPAP to support the upper airway and adding part. And that, of course, that was what became the bi-level system. All right, I've gone on far too long, I'm afraid, but I'd just like to say what is extraordinary about CPAP is that I know from recent information from colleagues at ResMed, they've got something like 14 million patients, 14 million on CPAP at home, and they're recording the CPAP use every night, not all night, every night, month on, month in. In a way, in a very real sense, it's repeating our original experiment on all of these patients every night. I think that I've probably gone on too long, and I would like to finish up here by thanking you for asking me to give this talk.